to correspond to the increase in blood glucose levels after meals. And this is what happened. This is when we give the insulin. When we eat, it just corresponds to it. Oops. And these are all kinds of insulins available in the market. Preparation, we have 3 short-acting insulin, 2 long-acting insulin, and of course the old insulin, the MPH, the regular, and lente and ultra-lente, which is kind of. Now, the new generation, I'm going to just mention a couple that came in the market this year. And a little bit more. This is a system, we just talked about pancreas. This is a system called the GLP-1 system. GLP is a glucagon-like peptide. It's a substance secreted by the gut, by the actually duodenum, and it has a lot of effect, or let's say control on multiple organs, including the beta cells, and it enhances glucose-dependent insulin secretion. It affects the alpha cell, decrease glucagon secretion. It also decreases glucose uptake, and also helps regulate gastric emptying and promotes satiety. So it acts like 5-6 sites, and therefore they found the substance, but it's normally we make it and break it in 2 minutes. So therefore they had to come up with something that lasts the enzyme degradation that we do in our body. So that's where the therapeutic potential for this. Companies had made 2 now in the market. We have one. The first one was exenatide, which is the Glia monster. It's from the saliva of it, and it's what it is. It resists the degradation, and it acts like a glucagon-like peptide and does the same function the natural peptide does. And there is in the pipeline maybe the extended release. The problem with this is not a problem, but you have to take it twice a day. The new ones are being studied and maybe approved. It's once a week. The other one, which is actually an engineered glucagon-like peptide agonist, it's made a glucagon-like peptide. It's the Victoza, I'm sure you all heard about, and the liraglutide. On the same token, as you saw that in the pancreas, in the gut, when the glucagon-like peptide gets produced, it gets destroyed. So if we can stop this destruction, we may increase our own production of glucagon-like peptide, and therefore they came up with the DPP-4 inhibitors. They are medications that inhibit the degradation of glucagon-like peptide and therefore increase the level available to be used, but they're normal levels. It's different from super physiological levels that are provided by injectable glucagon-like peptide. So where's the difference in this. And we have now 3 in the market: Januvia and Onglyza, selagliptin, and the new one is the Tradjenta. I'm mentioning this like the market names because you're probably more familiar with them. And the last one has the advantage, the new one has the advantage if people have renal insufficiency, it is hepatically metabolized, and therefore it is used in cases even in renal failure. This is the exenatide, the Victoza. The exenatide really, as I said, it can use with metformin, with sulfonylurea, combination therapy, and recently was approved with the long-acting Lantus glargine as early in the management of diabetes. Victoza also, it's act like a glucagon. As I said, it's engineered. It does all the function all glucagon-like peptide they do, and we have to be aware that it has a drug interactions because it delays gastric emptying and may impact the absorption of oral medication like digoxin, lisinopril, atorvastatin, acetaminophen, and these are very common ones. And the DPP, as I mentioned, if we block that enzyme, we will be able to increase our own native glucagon-like peptide, but this is very limited given the fact that type 2s are to start with are deficient, so it may help a little bit, but not as the super physiological injectable dose of Victoza or liraglutide. This is how they function. They block the enzyme And now there are other very similar to glucagon. It's a substance is made actually in the pancreatic islets, and it comes together with insulin, both type 1 and type 2 deficient in making it. It's called amylin. Again, this idea and this knowledge has been used to produce the pramlintide or the Simlin, which is another injectable medication that is now available for both, this one for both type 1 and type 2 diabetic. Type 1 can use it motivated. We give it a pre-meals and decrease the, does all of this and decreases insulin requirement, and therefore it helps with weight loss, which is an advantage very much, you know, hoped for during the management of diabetes. You don't want anything that makes you gain weight. All right. Now, the new things, this is well known. Welchol, I'm sure you're all aware of Welchol, but I have the other new thing is the bromocriptine. Bromocriptine has been manufactured and packaged to be used in the management of type 2 diabetes. Now is under the name of Cyclest, and it is 0.4 milligram, 0.8 milligram tablet. We increase up to 3 to 4. It is exactly the bromocriptine we used for a long time in the management of pituitary tumors, but it's a different dose. We still give it to the patient at night sometimes, which is the traditional use of bromocriptine for pituitary hypersecretion, and because it does still cause nausea, but much less side effect, and the mechanism of its action is unknown. It has a modest reduction in, it's expensive, it's very new, modest reduction in hemoglobin A1C are 0.5, maybe 0.8% hemoglobin A1C, and because of its expense, many doesn't recommend to use it. It's usually an adjunct or extra, the last thing we add, just so that people, if they want to avoid injectables. This is not in the market yet. This has been studied. It's very novel. There are a couple of studies being done on two items, glucagon receptor blockers. Stage 1 and stage 2 has been completed and showed good results, and it has a potential to be effective drug therapy in the future. It has some, we have some reservation about the increase in liver enzymes. Glucagon levels may go up, and they're talking about potential tumors, and it's producing a significant reduction in hemoglobin A1C. Few words about hyperlipidemia. In all you know that the vast majority of patients with known coronary artery disease and high risk or the coronary artery disease equivalent will require lipid-lowering agents. Statin is the #1 agent. There are many of them. Recently, you may are all aware that Zocor at high doses or simvastatin at 80 milligram has been associated with myositis and increase in muscle enzymes, and also it has drug-to-drug interaction that also further raised the level, and we've been adjusting that recently. I mean, they all have complication, liver enzymes as well as muscle inflammation. All of them, usually patient with risk and coronary artery disease treated with statin therapy when tolerated. It's needed with symptomatic carotid artery disease, peripheral artery disease, and aortic aneurysms. Multiple risk factors, that anything that gives, like earlier I mentioned, more than 10 years risk of coronary, like more than 10 years, above 20%, using the ATP3 modification of Framingham-Risk, because it's these risk table. We classify patients and we find out what their risk percentage over a 10-year period. Anybody who achieved 20% and over, they qualify for statin therapy. Chronic renal insufficiency, defined by plasma creatinine concentration that exceeds 1.5 and or glomerular filtration rate that is less than 60 as a coronary artery disease equivalent, and we do treat them with statin. Although there's end-stage renal disease, there's kind of debate about using statin in these patients. Men over age 40 with type 2 diabetes and any other risk factors, or over 50 without risk factors, women over age 45 with type 2 diabetes and other risk factors, or over 55 with or without. These are just the criteria of whom do we prescribe statins, which is the first line of treatment in this case. Cardiovascular benefits of cholesterol-lowering agent with statin has been established and demonstrated in many groups. I always tell my patients the only one we know that does something, although with we know all about the side effects and problems it creates and drug interactions. I know Dr. Sharafati is waiting. And current ATP guidelines for LDA lowering in patients with existing coronary are very much aggressive. We all recommend below 80 LDL, and some even advocate 70 LDL. And the non-HDL combined should not be more than 30 above the total LDL. Thank you.